Hello, this is Chris Peters, one of the musculoskeletal radiologists at the University of Nebraska Medical Center. I'm going to be reviewing imaging of the upper extremity with MRI, specifically the shoulder, elbow, and wrist. The first study I have pulled down today is our routine protocol for shoulder MRI without contrast. This is a fairly normal study for us to review a search pattern for. So our routine study encompasses 3 coronal sequences. We have a T2 non-fat saturated sequence here on the far left, a PD, proton density fat sat sequence here in the middle, and then a T1 weighted sequence on the far right. We also do a sagittal T2 sequence, an axial PD fat sat sequence, and then also on the bottom right here, an axial oblique PD fat sat sequence, which you can see is somewhat in plane, or tries to get in plane with our glenoid, and we'll talk about that more in a bit here. So my search pattern starts off with the rotator cuff on the sagittal sequence, looking at the muscle bulk, looking for atrophy of the rotator cuff. We have our supraspinatus, infraspinatus, and teres minor, and then our subscapularis muscle. This often will give you a clue as to whether or not any pathology you're going to see in the rotator cuff tendons are chronic or acute. So I typically will scroll out of the muscle and through the tendons. Usually I start supraspinatus and go posterior, infraspinatus, teres minor, subscapularis. And I'm looking at these really in all 3 planes. But this first sequence here, giving you an idea if there's going to be much pathology with the tendons. Also looking at the coronal. And with the coronal, typically I start by finding the long head biceps tendon here anteriorly in the shoulder. And once you find that and scroll posterior to it, you're going to be getting into the greater tuberosity, the proximal humerus, where the supraspinatus is inserting. So that's going to be the far anterior portion of the supraspinatus tendon. And then you continue to scroll posterior, evaluating the supraspinatus and infraspinatus tendons. A tip to evaluate the far anterior, outside of the coronal sequence, the far anterior portion of the supraspinatus is don't forget to look at your axial sequence. It can be very helpful for looking at real far anterior tears of the supraspinatus tendon. So after I've looked at the supraspinatus, another tip for the infraspinatus, if you look at our oblique here, the oblique's typically in a good plane to characterize the infraspinatus, much like the coronal here is for the supraspinatus. Our oblique is somewhat tilted to almost make the infraspinatus look like our coronal for the supraspinatus, if that makes sense. So it can be very helpful for characterizing infraspinatus tears, is our oblique. After that, like I said, we look at the teres minor, which all 3 planes, but the workhorse is really our sagittal and our axial for teres minor. Then I look at our subscapularis tendon. Again, sagittal and axial are the main workhorse sequences for subscapularis. Coronal can certainly be helpful too to evaluate each slip of the subscapularis. After the rotator cuff tendons and muscles of the rotator cuff, I move on to the glenohumeral joint, structures within and that traverse the actual joint. And I typically start just characterizing joint fluid, so give a subjective analysis of how much fluid is in the joint. Don't forget to look, fluid tends to like to accumulate in what's called the subscapularis recess here anteriorly, which you can get a good idea on the sagittal sequence, how much fluid is in that recess. But this is essentially a physiologic or normal amount of fluid in this joint. After joint fluid, I'm also looking at the alignment really on the axial and the coronal, just to make sure the glenohumeral joint's appropriately aligned. A little bit of posterior decentering of the humeral head's not all that uncommon given that the patient's lying supine. But certainly if you see superior migration of the humeral head, if it's moving superiorly towards the acromion, that's not normal. And will clue you to maybe some sort of chronic underlying. Usually there's a chronic underlying tear to go along with that. After joint fluid and alignment, I tend to look at the cartilage. And so your PD fat sat sequences here in the top, middle, and the bottom right and bottom left are going to be very helpful for looking at cartilage, looking at the glenoid. And there's different patterns of wear for cartilage, but often you'll see posterior or central glenoid cartilage wear with arthritis. And then make sure I'm using all three of these sequences to look at the humeral head. It can be challenging to evaluate the humeral head cartilage sometimes. So after cartilage, I'm going to look at the biceps tendon. So we found the biceps tendon initially on our coronal sequence here, far anteriorly. I typically will start with our oblique here. It's going to be very helpful for evaluating the long head biceps tendon as it traverses the intra-articular or the joint. And you can see it here traversing the joint. So our oblique is very helpful in that regard. Essentially really to find the long head biceps tendon throughout, and as it inserts us at the biceps anchor here at the superior margin of the glenoid. And after the biceps, I'll look at the labrum. And I look at the labrum throughout, but the most important, in my mind, the most important parts of the labrum where you want to exclude a tear is going to be a slap tear superiorly, and also the anterior-inferior labrum if the patient has a history of instability or anterior instability. So, like I'd mentioned earlier, we have this oblique sequence on the bottom right here, which it's about a 45-degree angle is what we tell our techs, but it helps us get in plane with the glenoid because the glenoid's tilted anteriorly. So I usually will scroll through on the oblique looking at our anterior-inferior labrum first. A little bit of infolding of the joint capsule here is normal. The labrum is nice and dark. I don't see an anterior-inferior labral tear on this patient. And then after I can exclude a tear there, I will promptly then go look through the superior labrum. And I start with the coronals. So it's normal to see a little bit of fluid interposed between the biceps and the labrum, and then to see a little bit of cartilage undercutting a portion of the labrum superiorly. That's normal, that's not a tear. And so I'll scroll through a few times on the coronal, and then I'll obviously use our axial and our obliques to help troubleshoot those areas of the labrum, and then also look at the rest of the labrum, like the posterior labrum and the inferior labrum. After I'm done with the labrum, I move on to some structures surrounding the glenohumeral joint. I move on to the acromioclavicular joint here superiorly. Really, the first thing I do is I'm evaluating for degenerative joint disease, osteoarthritis, and giving my subjective opinion on how advanced that is, if there's any joint fluid, if there's any osteophytes or capsular hypertrophy that may be impinging or abutting the underlying rotator cuff muscles. I'm also looking at the acromion, specifically in the coronals, looking for any downsloping of the acromion, any spurs coming off of the acromion, which may impinge upon the rotator cuff. It's also important to take a look at the acromion on the sagittal. There's various morphologies of the acromion, which could have impact on the traversing underlying rotator cuff tendons. Next, I tend to look for fluid in the bursa, the subacromial subdeltoid bursa, and quantify how much fluid is there. After I look there, I kind of move on to some more miscellaneous structures around the shoulder. So I tend to look at the rotator interval, and I come down here to the sagittal sequence. So I'm looking anteriorly for the coracohumeral ligament here, and this is our rotator interval, making sure that there's normal fat, bright T2 signal here surrounding the coracohumeral ligament. Essentially looking for signs of maybe a capsular sprain or adhesive capsulitis. And I usually, as I'm looking for that, I'm also taking another look at the inferior capsule of the glenohumeral joint, the axillary recess here, looking to see if this capsule is thick or if there's increased signal, which may clue you into signs essentially of adhesive capsulitis. After that, I return to the coronal sequence in the T1. So now I'm going to look at marrow. Essentially, I'm looking to make sure that our marrow's bright on our T1 here and there's no pathologic marrow replacement process. After I look at marrow, I briefly scan through the axilla, make sure I'm not missing anything in the axilla, on our axial. And that's the essentials of my search pattern. Some other things to note, I do tend to look at the deltoid muscle at the end just to make sure that there's no atrophy or abnormality with the deltoid. The deltoid is innervated by the axillary nerve, so any signal abnormality or atrophy with the deltoid, you should be looking at your quadrilateral space here, inferior to the glenohumeral joint, which would also affect the teres minor muscle. And then in that regard, I see pathology in supraspinatus or infraspinatus in isolation without a tendon tear. I tend to look at our suprascapular notch, which is going to be at the base of the coracoid as it joins the scapula in this region, as the suprascapular nerve innervates the supraspinatus and infraspinatus, and then also the spinoglenoid notch as the suprascapular nerve continue on to innervate the infraspinatus. So that's the essentials of my search pattern.